Welcome to the Clinical Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsors, Limmer Education and ESO, we are able to make science more accessible and understandable.
Thank you so much to all of our attendees for joining us today for the October 2025 PCRF Journal Club. I'm thrilled to bring to you the authors of this recent publication, Barriers to Buprenorphine, a case series of misadventures implementing a pre-hospital buprenorphine protocol. Again, we're excited to bring the authors and their brand new research to the team, and to all of those attending. A big thank you to Limmer Education and ESO for helping to sponsor this month's podcast. Today, I'm joined by Dr. Tony Fernandez and Jeff Rollman, who will be sharing their insights along with several members of our author team who helped provide this research and write it up and get it submitted. And you can find this article in a special case series or a special series by Pre-Hospital Emergency Care that focused on opioid overdose awareness, education, and the EMS connection there for treatment of all of their patients. So really excited that there's a special edition for PEC focusing on, again, this common call that we go on as EMS providers and just the general treatment that's going on across the country. There are programs that are really taking a forward-thinking approach, and I'm thrilled to bring some authors in who are doing exactly that. Again, all of our podcasts are associated with a article written in Journal Watch. And if you're attending EMS World here in a week, you'll find that one of our articles is featured in the EMS magazine. So we're thrilled to be bringing that research to the forefront and sharing that with all those that get the EMS World magazine, but then we'll be attending in person here in just a week. Again, with that, I'd like to welcome our authors to this stage to share a little bit about why they got this research going. But first, we want to know who they are and where they're from. So I'll turn it over to the primary author, Parker Bales, to give us an introduction, who he is, why he got this research started, and why he's excited to share it with us today. Go ahead, Parker.
Good morning, good afternoon. My name is Parker Bales. I'm a community paramedic in the upstate of South Carolina. I work for Prisma Health, which is a hospital system here in the upstate and into the Midlands, middle part of the state. I got attached to the buprenorphine protocol after it was already somebody else's brainchild. So I came in as the research coordinator, but from what I was seeing in that role, we developed the case series to kind of review retrospectively patients and how the protocol was rolled out. So I can't say that this by any means was my protocol or my baby. This was all Dr. Gormley and Dr. Michella spearheading this. With that, I'll pass it on to Miranda.
Hi, everybody. I'm Miranda Gormley. I'm the epidemiologist in the Prisma Health Department of Emergency Medicine. I do a lot of the research for the pre-hospital division, which is where our mobile integrated healthcare program or community paramedics are. In 2023, we were given a seat grant of about $20,000 to start this program, which we called the Pre-Hospital MOUD in South Carolina, Our Endeavor or Premise project. The project allowed us to give buprenorphine to people on our paramedics on our 911 units in rural Oconee County, which is a little novel because a lot of the programs that you see are urban based and ours is rural in the upper part of the bottom part of Appalachia. So we're really excited to talk to you about this today. And with that, I'll turn it over to our other community paramedic, Wes Wampler.
Hi, my name is Wes Wampler. I'm also a community paramedic with Prisma Health. I work specifically with the Addiction Medicine Center. I've been working with them exclusively for the past 2 years, I believe. Ditto to what Parker said and Dr. Gormley said. Additionally, we've kind of looked at the stigmas to EMS providers and EMS clinicians and how that's kind of impacted treatment and the implementation of a protocol such as this. And we've looked at how people have perceived buprenorphine, what they feel about Narcan, and kind of expanded on the implementation of buprenorphine in the pre-hospital setting to the EMS setting. But I appreciate the opportunity to be here.
Well, we're thrilled to welcome you. And again, just hear about your perspectives. I'll have to be honest that you picked 3 really interesting case studies to look at in your series here. I was reading them and I was like, ooh, this got good. So I'm excited for you to share those with us. More importantly, maybe give us a little introduction as to why this was a topic of choice. It sounds like there was some grant money in it, but I have to be honest, when I think of the opioid epidemic, I don't always think of South Carolina, but you do a nice job in your introduction sharing why. And I think our attendees would be really interested to hear that.
So I'll cover a little bit about that. I think a lot of the programs that we see that have pre-hospital buprenorphine programs are mostly out on the East Coast or on the West Coast, and there's none in the South. And yet the Southern United States has a huge problem with opioid-related deaths, specifically in rural areas where our patients have a very difficult time getting appointments for MOUD. There's a huge shortage of healthcare providers, and there is stigma, which Parker and Wes will hit on a little bit later, not only among the people in our communities, because there's a huge community stigma about receiving or going into recovery, right? But also kind of among our healthcare providers. So one of the reasons that we wanted to touch on this is we were trying to get this protocol off the ground, and we were having issues. Like, we just kept running into these roadblocks, and I noticed in research there were no other studies that covered the issues that people were running up against when they were trying to implement these programs. So we felt it was really, really important to share our experiences so other people would A, know that they're not alone when they're implementing their own programs, and B, things that they should watch out for so that it can inform their education programs when they're trying to get these off the ground.
Oh, I think that's great. And again, you think of all the different places where we see our whole blood programs, another innovation coming to EMS. And you're right, it's in a lot of rural places where we know the victims that will probably most benefit from it are not those people, because they do live within a very close range of trauma centers, things like that. So maybe give us a little bit of foundation too for the system that's administering the medication, ALS system, a little bit of the history. What does the community paramedicine sort of look like? Like, who are they responding to? What's their primary role within the system?
So the system is run by Prisma Health EMS. So in the southeastern United States, for the most part, it's third-party service, right? Greenville County has Greenville County EMS. Pickens has Pickens County EMS. 49 years ago, next year will be the 50th year, but 49 years ago, the hospital overtook the ambulance service for what it was at the time, right? Took it over from the funeral homes. And since then, it has always been attached to the hospital system. So with the merge, or whatever they want to call it, I don't know specifically, so forgive the vernacular, but about 4 years ago, 5 years ago now, it became Prisma Health as a whole. And that crosses from Oconee County, which is, if you look at a map of South Carolina, the very top left corner. And then it runs down into Greenville, Lawrence, south of there, and into the Midlands, the Columbia area. So it's a big ambulance service, but specifically to Oconee County, we run the 911 service there. So ALS level trucks across the board. They run a couple BLS trucks, but they're solely intended for transfer on the private side. Occasionally they'll run backup on 911s if they show up first, but for the most part, it is a purely ALS system with 2 supervisors on. And then we happen to have 3 community paramedics in Oconee County who meander and see patients on a scheduled basis, but they weren't necessarily seeing these patients intentionally. Wes was doing some follow-up with them during this protocol, but as far as community paramedics, they weren't truly attached to the response plan. Part of that was when the protocol was developed, we wanted to put buprenorphine in the hands of paramedics on the ambulances who were going to see the patient 24/7. We didn't want to worry about, oh, it's 3 o'clock on a Tuesday morning, we don't have a CP on, right? So we made sure that the education piece went out to every paramedic attached to Prisma Health in the upstate, but notably, before the first dose of buprenorphine was administered, every paramedic attached to Oconee had received the training. Like, I was chasing folks down on a Tuesday, like, hey, we're going to sit in here, you're going to be out of service for an hour, let's do training. So we made sure that every paramedic attached was trained on it, as well as the BLS providers. They had an awareness too. So.
Nice. What does because mobile integrated healthcare and community paramedicine means, if you've seen one system, I think you've seen one system, and it means a lot of different things to all different places. What would be a typical day look like for a mobile integrated healthcare paramedic in the system?
Unfortunately or fortunately, we've got about 7 or 8 different silos we work in, which has made us very sustainable as far as the service is concerned, right? Prisma reaches to us as the Mikey, right? Mikey will eat it. We get phone calls from everyone about everything. The standard model for our CPs, though, the vast majority of call volume comes from patients that were admitted at the hospital and needing follow-up care that home health or PTOT or whomever won't be able to meet due to social determinants of health and payer mix. So most of our patients are attached through comorbidities and social determinants of health. So our CP's standard day is I schedule 4 or 5 patients to see on a day. I see them on about a weekly basis, get them over the hump of getting home, make sure everything's square, and then graduate them out of the program. So, but in between those calls, and what does happen from time to time is I am up in the north end of the county and hear a call come out and I'm 20 minutes closer than anybody else. I'll call my patient and bump them for 30 minutes while I go do this 911 call. So that does happen from time to time.
I think that's really interesting. It gives a little bit of an insight into what they're doing on a daily basis, right? I always wonder when we task our mobile integrated healthcare paramedics to do new things, it's like, do they have experience dealing with a patient in crisis, right?
Mm-hmm.
Because a lot of it is this hospital at home type
Mm-hmm.
philosophy. So that's really interesting that they can sort of shift between, or there's a bit of quite a wide spectrum to what the mobile
Mm-hmm.
integrated paramedics are doing. I think that's great. I think I have one more question on introduction stuff, and then I want to open up to our other panelists to see what their questions are. But bridge the gap for me and for the audience on, so we got a grant to do some of this, and this is the topic we're going to use it. But what sparked the idea to go get some funding in order to implement a program such as this?
So we saw that a lot of we wanted a way to get some of these people who weren't coming to the hospital into treatment. And one of the programs that kind of inspired us to branch out into buprenorphine and trying to connect with individuals living with opioid use disorder was our HCV program. Because right now we have an HCV program that's based on we diagnose them with HCV in the emergency department. We schedule them treatment for outpatient office-based care, but they don't show up. And so what we ended up doing was scheduling a community paramedic to go out and do a telehealth visit with them. We wanted to replicate that model to see if we could get more people into treatment for opioid use disorder. And so we decided to start doing it by putting it on the 911 rigs, which would make, we felt by treating an individual's opioid withdrawal would make them more amenable to having a conversation, to going into treatment. And then towards the end of our pilot, we finally got enough money to bring Wes aboard, and he started contacting these patients. So that's kind of the evolution of how we got here. We started with that HCV program and we worked our way into opioid use disorder. And one of the big reasons is 100% of the people in our HCV program are injection drug users or former injection drug users who needed some type of treatment. And half of them we ended up connecting to treatment for opioid use disorder. We wanted to see who else was out there.
I think that's so interesting, and it really highlights the more and more public access naloxone we're seeing are huge amounts of cases that are never making it into the healthcare system, right? And naloxone is administered in the pre-hospital setting, if you will, before EMS even arrives, or if EMS arrives at all, and the patient may return to baseline. I know we routinely have comments and questions about like signing a refusal form or against medical attention, in the pre-hospital setting. And it's like, no, actually, this is happening. And if we don't have a method for it, people are just going to stop calling because they know that they're going to get taken to the hospital where they may not want that, or that treatment may not have been necessary. So really, really interesting. I want to open it up to Tony or Jeff. Any questions for the introduction? Otherwise, we're going to have Tony transition us into the methods.
Quick question about the context. And first off, just wanted to thank you all again for joining us. It's so great to have all of you here to be sharing this really interesting work and gives a lot of excellent information in the paper that other EMS agencies can look at. Was wondering a little bit, I guess, just on the kind of background regulatory context, because I know there might be some paramedics or medical directors listening and thinking, there is no way we could do this in my state or in my agency. If you could speak just a little briefly about what barriers maybe you encountered and if this was something that other agencies were already doing or you really had to work and kind of push against the grain a bit.
So I'll tackle that one. So we decided to propose this as a pilot project to our state EMS board, and we were given approval by the state EMS board of South Carolina to do a 1-year pilot project. After that 1-year pilot project, we went to produce or to present our final results of the pilot, which suggested that it was wildly popular. We had several other EMS agencies in South Carolina adopt our protocol and start their own programs. And we found out at the state level that in fact, community paramedics in general should not have been producing or administering buprenorphine. So our project was put on hold. And so we are currently, even though we have the blessing of the state EMS board and the blessing of the head of our Department of Public Health, we have to wait for the DEA to approve I think it's a waiver for us to be able to continue providing buprenorphine in the state. Unfortunately, there was an administration change when we decided to, when we realized that this was a problem. So we are still awaiting permission to restart our program. So that is a huge barrier that we are facing in South Carolina.
Yeah, well, I hope you can get past that barrier. But just the
You know
fact that you were
anybody at
able
the
to get that.
DEA?
But the fact that you were able to get that pilot in, since a lot of areas don't have any framework, and it seems like you didn't have that prior, but you were able to push through that pilot. So kudos, and looking forward to talking more later about your work.
Great question and a great update on the program. But let's start with where it started. Tony, you want to tell us a little bit about the methods for this case series?
Fantastic. Well, thank you so much again for joining us today. I really think that this is going to be an important addition to the literature, and I'm excited to talk to you about it. So let's start off. I think we kind of played around the edges here, but let's jump right into what your objective was here. And the idea was to highlight 3 patient case series where barriers were encountered during the first 6 months of implementation of the program. And before we get into kind of that, I think you gave us a little bit of a background about Prism Health, but if you can kind of dive in a little bit deeper and tell us more about the population you serve, because I think it's really important that this was done in a rural area and not so much in an urban area where we see a lot of these first initiatives.
Parker, do you want to cover that, or would you like me to cover it?
I can cover it. I was just making sure my numbers were right. So Oconee County is a rural county. So it's separated 2 counties away from Greenville County, which would be our closest urban center, right? Population of just shy of 83,000 people, and I think somewhere in the neighborhood of 500 square miles, if I remember correctly. I can't remember the exact call volume for Oconee County specifically because call volumes get thrown around for the ambulance service versus just the county, right? But for the year, we ran 111 overdoses or calls that would classify in and around overdose, right? Some of them were cardiac arrest with suspected opiate use attachment. Some of them were unconscious faintings that were then turned into overdoses, right? So 111 patient contacts over the course of 12 months that we deemed opiate adjacent, if not definitively opiate. And I'm sure there are systems out there that do that in a month, right? Versus Oconee that did it in a year. So when you talk about the call volume and the county, it's just a different thing you're fighting. And that's just the geographic location of it, let alone the people that are in it, right? As Dr. Gormley noted to earlier, your population isn't going to be as forward thinking when it comes to recognizing opiate use disorder as a disease and not a decision. And so that was a big part of what we recognized through training. And what I mentioned before with the 100% compliance for training, I taught many of the trainings, as did Dr. Michella, Dr. Gormley, Wes. And there was definitely some glazed eyes during the training. And I know that's not always because of the subject matter, but I suspect part of it was due to the subject matter.
I'm sure it certainly wasn't the instructor. You seem very engaging. And I'll tell you what, I've had plenty of times where my audience was glazing over. So kudos to you for pushing through that and getting this important information out. So I thought that this was also really interesting. It says in your paper that the majority of the non-fatal opioid overdoses, they were transported to the ED of a rural community hospital that actually had resources specifically for individuals with opioid use disorder. And I think that it's important to talk to our audience about this because when you think of rural community hospitals, you may not think about these extra resources that they have. So can you talk to us a little bit about this and how that was integral to your project?
Absolutely. So unfortunately, Dr. Phil Michella couldn't be with us here today. He has spearheaded the Screening, Brief Intervention, and Referral to Treatment program, also known as SBIRT. And he's done that in both our hospital here at Greenville Memorial, which is our large urban academic level 1 trauma center, and then out at Oconee, which is our much smaller rural community healthcare center. And so basically what SBIRT does is it allows the nurses to ask a screening question to see if individuals have a substance use disorder very early on in their treatment. I mean, they can go in with a stub toe and they can get those questions. And then if they are screened as positive for substance misuse, they will talk to one of our certified peer recovery support specialists, and she will help guide them into treatment. There are, as we have mentioned, few treatment options in Oconee County, but we are also very lucky that we have a NIDA grant that allows us to have a mobile center out there for helping individuals with opioid use disorder. And so they can go almost immediately to seek treatment there. And of the individuals that Wes connected, all of them went to that mobile unit. So that's one of the big things that we can do in this rural area. We just happen to have a lot of really good resources. Now, it's problematic for some of the people that were in this particular pilot for premise is that a lot of them arrived at night and our peer coach only works from 9 to 5 Monday through Thursday. There's also only one of them out there because like all rural healthcare systems, it's very, very hard to find peers who would like to work out in the rural community center. So that is a couple of the things that we have struggled with. Additionally, even though we've had the ability for emergency medicine physicians to give buprenorphine, we've had that pilot going on for about 5 years now. A lot of them are very hesitant and don't like to talk about giving buprenorphine. And this is something that we experienced with 2 of the physicians that were in this pilot. So that's one of the reasons why we chose these cases.
Interesting. That's really important information. Thank you for sharing. So let's dive in a little bit to the protocol. So can you talk to us a little bit about how patients became eligible to get treated in this protocol, and then some of the exclusion criteria?
So it initially started with anyone who was, for lack of a better term, revived with Narcan, right? So they received Narcan either from the bandoliers of Narcan carried by law enforcement or whatever shows up with EMS. Once they're up, awake, talking, they're able to protect their own airway. We move to the COWS score assessment, the clinical opiate withdrawal scale. If the COWS score was greater than 5, they met criteria. Dr. Gormley, Dr. Michella did their research on the back end ahead of time to find that 16 milligrams was the right dose 90% of the time for patients. So they gave 16 milligrams as your initial dose with an ability to give another 8 milligrams if their COWS score remained elevated after 10 minutes. And then the hope was that it would be something to help them go to the ER to meet these SBIRT folks or to get the SBIRT exam and then meet with peer support counselors. But even if they didn't, the thought process was that they were safer at home with the buprenorphine on board than if they were just left to their own devices, having received a bunch of Narcan and being in acute withdrawals. I will say throughout the protocol and kind of the evolution of the protocol, there's 2 or 3 different times where a sick person type call was made, and the paramedics on the ambulance were able to recognize this seems more opiate withdrawal symptoms. called, spoke with the physician on call, because we had to call every time we administered, spoke with the physician on call. We were outside of a window for causing precipitous withdrawals, and they would administer buprenorphine to these patients, even though they had not received Narcan. So there's a couple of times we were actually starting to expand the protocol to say, hey, we recognize this as opiate withdrawal symptoms, but we're just because we're lacking the substance, not because they'd received Narcan. And so there was a couple times we administered in that case as well. And like you had said, most of our patients went to the ER through this protocol as well.
Interesting. And you mentioned the clinical opioid withdrawal scale. Can you describe that a little bit for folks on the call who may not be familiar with it?
Yeah. So if you think of any patient you've ever woken up with Narcan, the sweating, nausea, vomiting, diarrhea, the agitation, the discomfort that they're feeling, it's not hard to get to a COW score of 10, right? I can think back to my time on an ambulance, which is now getting to be years ago, that I was doing it full time. And I can still remember like waking people up with Narcan and just kind of what I remember thinking back now, and I'm coming up with a COW score of 5. Heart rate, um, uh, skin condition, agitation, piloerection, or goose flesh, like all of these are things that help you build that score up. And we'll actually touch on it some in one of our case reports.
Fantastic.
I do want to mention
Please.
that sounds really complicated to try to calculate on scene, right? So we ended up putting that into our image trend so that people could just click on the boxes and calculate the score so that they didn't have to do the math themselves.
Yeah.
That's great.
They had physical sheets in the ambulance as part of the Bupe kit, so to speak, that had the phone number to call and then a COW score right there that you could fill out if you so desired. But like I said, it was not hard to get above a 5. If you just think to anybody you've woken up with Narcan recently, it's pretty easy to get there. So.
Yeah, and I think that's a great point. And thank you for going over that score. I think that that's really useful now, and the more folks know about it, the more we can utilize it in our field. And really, I think it's a great idea to put that into your electronic health record. The less math we have to do in stressful situations is probably a good thing, right? Okay, so let's talk a little bit about how you administered buprenorphine. So they had a COW score. They clearly were patients who were met the inclusion criteria, and you didn't exclude them. They met your COW score. Then how did you treat these patients?
Then it moved to the exclusion criteria. You had asked about that before. It was mostly the research exclusion criteria. It is safe for pregnant people. It is safe for kids, under 18. But those were 2 that were excluded. If you were in law enforcement custody, you were excluded. If you were suicidal, homicidal, you were excluded. Right, the usual research criteria were our only exclusions. There was nothing in the medication or, forgive me, methadone. If you had taken methadone, you were not allowed to take buprenorphine. That was the only one specific to this medication. Otherwise, it was the usual exclusion criteria. If you met the COW score of 5, the phone call would be made to the physician. And that was another thing that we had some issues with in the rural county. You get up into the mountains of some of these areas, and cell service didn't work. So I'm aware of some providers that got personal cell numbers of ER physicians and were texting them reports.
Interesting.
Very vague to keep it HIPAA compliant, but COW scores to say, hey, can we give it? And yes, go ahead. Right. So I don't know how politically correct it is, but they were doing the best thing for the patient, right? It's defendable in my purview. So I'm aware that happened a couple times. So once that contact is made, yes, it sounds like a good candidate for buprenorphine. It's a sublingual tablet or film, depending on who you purchase it from. And then you're able to administer it that way. You're also given a little bottle of water, which was the biggest stink in the world, apparently, that we were giving patients. I don't know what it was, but that was the biggest, what about the bottle of water on the truck? To give them something to moisten their mucous membranes, because it'll dry you out pretty bad, as I understand it. So
interesting. Who knew that water would be the sticking point, huh? Well, thank you for that. And so I really like that we're finding out more and more uses for and places where community paramedics can step in and fill roles. And I love the way you used your community paramedics in this pilot study for some quality assessment chart reviews. Yeah, they've got a lot of expertise, and certainly these chart reviews are not the easiest thing in the world. So can you talk to us about kind of how community paramedics kind of stepped into this role?
I guess I'll keep talking here. So I was working, part of the many different silos that we have is a 24-hour coverage for our MIH program here at Prisma. I was working nights at the time, and our primary role was to see patients at nursing homes. There are not many nursing home calls at 3 o'clock in the morning. So I had something to fill my time. And that was primarily what I was doing. So I would come in, I would pull from image trend each report in our criteria to make sure we caught all 111 calls. And then I'd go through and just read them all. I'm fortunate that it was an organization that only had 110 and 111 in a year versus one that had 111 a month, right? I don't know that I could have worked a full-time job doing CP work and reviewed that many reports. And so having the time to dedicate to it, like you said, it's laborious. And then
Whereas,
for us being part of the healthcare system on a whole, I then put that patient's name and birthday into the hospital's electronic records and looked up their reporting as well to see the transition from paramedic report to nursing report and physician's diagnosis. Like, did we miss anything from point A to point B? And that's where we'll get into case study 3, where we noticed that there were some discrepancies in one report versus the other. And so through that 100% QA process, which I think helped, to answer a question earlier, helped us
I
get
bet.
on with the state, right? So the state knew that it wasn't just going to be like a here, go play and see what happens. We checked behind every report that buprenorphine was administered or when it could have been administered.
Yeah, what a labor of love there. Yeah, thanks for doing that, because that was really important for the paper, and it's nice to hear that that was important for other things as well, since you put in all that time. So I always have the unenviable task of holding us up some really important and interesting results. But before I open it up to our other panelists for any methods related questions, and then we jump to results. I think that the training that you did and the implementation of the protocol was novel and unique. And you talked a little bit about it. I just wanted to give you an opportunity if there's anything else that you thought was important to share about training or implementation of these protocols that folks may be able to use as they investigate this in their own systems and regions.
So I'll start that a little bit, and then I'm going to turn over to Parker because he taught a little bit more than I did. So we felt that it was really important to have conversations with everybody before we implemented the protocol. So as we were developing it, we developed it together with addiction medicine physicians, emergency medical services physicians, and EM physicians, right? Then we went and talked to all of the operations supervisors to make sure that they were on board with the protocol, understood it, asked them if they had any questions, and then we just asked them, what are the number one barriers that you think that we are going to have with the providers, like the EMS clinicians? How do you think they're going to push back about this protocol? And then we tried to adapt that into our original training. So we decided to make sure that we went to the required mandatory training. We got a 60-minute session the year that this was implemented, and either Dr. Michella or Parker went and did each of the teachings. They were available afterwards to talk to everybody. We did have everybody take a quiz to make sure that they comprehended like different parts of the protocol. We asked people if they had any questions about the protocol, and we made sure that we did all of that before we laid it out. So I think, Parker, you caught 2 or 3 stray paramedics after the protocol was implemented, right? But that was it. Parker made sure that we educated 100% of the paramedics who would be implementing this program in our agency.
I'll speak kind of 2 different points to that. Like Dr. Gormley had said, yes, we had 100% compliance before administration, and we went live on August 1st. And on August 10th or 9th, somewhere in there, I caught the last 2 paramedics that I was needing to meet 100% compliance. August 11th was our first administration. So it was just by happenstance, but I was just trying, people on vacation, out, whatever, part-timers. And so I made sure that we had that 100% compliance. For me, on a personal level, I'll be blatantly obvious or honest that part of the reason I moved from the ambulance world to the CP world was working in Greenville County. It's an urban center. I wound up running a lot of overdoses and felt frustrated that it was like, why don't you just stop doing this? Right. So I personally had that provider fatigue and did not have the knowledge that I have now. And so when we taught this protocol, we made sure that there was a part of it that really touched on the pathophysiology of this medication, both the illicit substances, the Narcan, and the buprenorphine, to better get paramedics to understand that this isn't a decision people are making, that this is a disease process like diabetes, coronary artery disease, or anything else. And so through that understanding, I then became much more passionate about how I teach this. And from this, I've been able to teach addiction as a disease separate from buprenorphine a couple different places because I have a much better understanding of this disease process than I did before. So that was a huge part of it. It wasn't just give 16 of buprenorphine, yay, the end. Like, here's why we're giving it and here's why we're doing it now. Touching on the SBIRT program, touching on the peer support counselors as things that are now in place where if we had implemented this protocol 2 years before, it would not have been as successful.
Yeah, well, thank you for diving into that. That's so important to do what we can to try and change that mindset. And yeah, strong work. Again, really congratulations on this paper. I think this is a great additional literature. And I'll open it up to our other panelists or anyone else on the call if you have any other methods related questions before we dive into the results. And thank you again.
I was just going to comment while we see if anyone else has anything. Thank you for sharing the education and the training. I think as we look at many research that have driven clinical practice over the last, we look at what the success depends on if the paramedics and EMTs were properly trained. And there's so many results that are impacted by that. So I think that's so important. And I appreciate that you shared it. Jeff, any questions on the methods?
I mean, you all covered the methods really well, and I could see that this was a comprehensive training program that you put a lot of thought into it. I guess tied to training was a little curious about whether there was sort of an outreach effort in the sense of almost training first responders, law enforcement, maybe the dispatchers, the 911 call takers, because we know there are many situations where, bystanders are administering the Narcan, or there could be barriers that can make things more complicated, that getting the community on board and trained in a sense could have a benefit.
So that's a great question. So we actually just got a 1-year grant from the South Carolina Opioid Response Fund to be able to do this for the next year. And even though we can't provide buprenorphine, one of the big important things that we are doing with that grant is continuing our training about addiction as a disease, right? And so one of the things that we have written into that grant were to contact law enforcement officers and then first responders. And by first responders, I mostly meant fire first responders. But I didn't actually think about communication staff. So that is definitely something that I will talk to the community paramedics about when we start figuring out our training plan and the individuals that we're going to reach out to. That's an excellent idea.
Sure. Yeah, I was just thinking about my own experiences in these situations where the patient's often gone by the time we get there because the bystanders have already administered Narcan. But if the 911 dispatcher could share that there might be additional resources, hey, can we try to get them to stick around? Then that might help a little bit. But super work, and that's amazing that you got that grant and you can continue this.
I think that quite nicely sums us up into going into the case series. The author shared a bit of some results about sort of overall eligibility and the administration and how successful it was. Happy to have you share that and then dive into the first case series and the interaction between the patient, the providers, the hospital staff, because your timeline details it all quite well.
Parker, did you want to share the first results?
I can, yeah. Sorry, I was trying to find the unmute button.
Oh, that's okay.
So case one was a young lady who was overdosed on presumably fentanyl. Bystander CPR was attempted. And then, like we've discussed, law enforcement was the one who actually administered the Narcan. So when EMS arrived, the patient was already awake and her chief complaint was chest pain, secondary to the CPR that she had received. Presumably pretty effective CPR because she had some bruising to the sternum noted in their documentation. This was the first patient to ever receive buprenorphine in the state of South Carolina pre-hospital. And then count scored 9, perfectly met criteria. They got the go ahead to give buprenorphine. And then at the ER, the issue that we came across was that the physician at the ER vehemently denied signing the EMS paperwork. And so I don't know how it is everywhere else, but in the state of South Carolina, if you give a controlled substance or a restricted med, you have to have a physician sign, and the physician denied signing. And this is where we start getting into the multidisciplinary team that was on this pilot, not just this paper. We had Dr. Michella, who's a ER physician, EM physician, and he worked with that same physician in the ER the next day just by happenstance, and had a cordial discussion, physician to physician, right, peer to peer, to say, hey, why didn't we sign? Here's what I know. Here's the science. And then from that, as I understand it, that physician, the one at the ER who initially did not want to sign, has prescribed buprenorphine since then and has kind of started becoming another champion for this medication in the ER. So we go from, a doctor unwilling to sign to having a collegiate discussion with their peer. And from that, you create another positive person for the protocol.
I noted just a couple things because I thought this case, again, I think they're all really interesting, but this one, so how much of the medication the patient received, because the protocol was like 16 and 8, if I remember
Yeah.
correctly, as you described it. So this patient received 16 milligrams and had a fairly good resolution of their withdrawal symptoms calculated by the cows, which I thought was interesting that is nicely documented in here too.
Mhm.
To sort of see that improvement. It's sort of, this is the medication we're giving in the pre-hospital setting and we can see the results instantly. I think, again, as we look to our providers and the why behind giving a lot of medication, it's those ones that can provide some realistic benefit to us in the moment that seems to be the easiest to adopt. So the patient only received the initial dose, which I thought was interesting. And then I just wondered if the physician said like, oh, I had no idea this was going on, or if they had a reason that they're maybe less familiar with the EMS system, maybe they're not in the ER very often, or if there was any rationale that was given behind why.
I can't remember specifically. As I remember as best I can, this was a physician that was normally at the hospital. This wasn't like a one-off thing. And then I know that anecdotally, we had lots of folks who were like, I don't know about this, particularly at the physician level, right? I just had an X waiver I had to sign 2 years before in order to even prescribe buprenorphine. And now I got these yahoos out here giving it on the ambulance, right? So there was definitely some like trepidation there. And so I think that's more where this is coming from, not so much I didn't know, because we did try, right? You can't talk to everybody all the time, right?
Oh,
It
sure.
took lots of legwork for me to make sure that we had and we had only 100% compliance for the paramedics. There were still some EMTs that I was trying to get in touch with to give them at least a passing understanding of the protocol in through and August, September, October as we implemented it. So the physicians moving around like they do in the Prisma network, right? You could just randomly on a Tuesday say, hey, I want to pick up a shift, and now you're in Oconee. I don't know many doctors that would want to do that. They're not quite as bad as paramedics about just picking up when they can, but it was a possibility. So we made a concerted effort to try and hit all the physicians we knew would be in Oconee.
Sure.
But we can only do so much.
No, very much understandable. And again, the fact that you've clearly documented the physician went on to prescribe it again and sign the form again, I think shows that simple conversations go a long way. And it's not always a PowerPoint presentation that's necessary, which is nice. I did note just in your case study too, the patient stayed almost 4 hours in the emergency department and was treated. Their chest pain was, based on what you've shared, was treated for many things to ensure that the patient didn't have any subsequent signs and symptoms. I think as we look at oftentimes maybe giving the medication and transporting as we look to the future, maybe the patient doesn't end up at the emergency department. This patient, again, ended up in there and was discharged very safely home without an admission. And I think as we look to, 20 years ago when naloxone required a transport, and now it's fine to be given in the pre-hospital setting. And for the most part, the patients do quite well after they receive it. These are the things that I think help drive us towards the future and are interesting. I did wonder, do you think the paramedic's perception was influenced by the physician not wanting to sign the form, or do you think they were just like, ah, we'll figure it out later and move on? I just wondered if you had any thoughts or if they shared anything like that with you.
I do want to point out one thing. One of the biggest barriers that we heard from the operational staff before we implemented the protocol was that there were physicians that they knew were not going to sign. So we fully expected it, and we did
Okay.
tell people we had a plan in place. Like, we told people, if they do not sign it for you, you call Dr. Michello or Dr. Wook Beltran, who is our medical director, and then they will sign it and have a conversation with the physician after. So we did have a plan in place to address this. But Parker, you could go ahead to answer the rest of that question.
As far as the provider, I knew that they, again, anecdotally, just chit-chatting with crews like I was able to, they were looking forward to having this on the truck, that paramedic specifically. And so he ironically had been a medic all of, 14 days when he was able to give it. So it was pretty neat for him to be both a brand new paramedic and the first one in the state to administer it.
Oh, that's super cool.
And so even with the aw shucks of the doc didn't sign, he was still, on cloud nine, being a champion for this protocol.
Great. And I think the brand new paramedic right out the gate almost always going to be the first person to try the new thing, right? Which we love our early innovators. But I think good to know that it didn't impact their decision making. But I think something that, like, yeah, it could be sort of a concerning moment if you were not bought into it and a physician was like, I'm also not bought into this. It certainly could impact your perception of it. So, and very interesting. And I'm glad to hear that there was no long-term change in that. Anything else? Otherwise, dive into case 2.
All right, so for case 2, we've got a young man overdosed potentially on fentanyl, but an opiate. Fire department was first on scene. They initiated bag valve mask ventilations with 4 milligrams of intranasal naloxone. EMS arrived, found the patient to still be unresponsive. They gave a milligram intramuscular of Narcan. They obtained an IV. The patient had a period of transient awareness before becoming unresponsive again. They gave him 0.5 milligram IV. So a good job titrating to effect here, our different uptake versions through IM versus IV, and making sure to not just slam 2 IV a la Code 3 if we've just seen that movie. And then we've got when the patient gets to the ambulance, a COW score of 21, so more than acceptable. Med Control approved buprenorphine administration with Zofran IV for how nauseated the patient was. On the way to the hospital, the patient becomes unresponsive again, requiring another 0.5 milligram of Narcan. And then at the ER, I appreciated in the documentation that they said that arrived to the ED, patient has projectile vomiting but remains awake and denies any complaints after this episode. So it was like, just I love the creative charting that we sometimes get into. So EMS crew did a phenomenal job. They were titrating to effect. We can on Monday morning quarterback and say they sat in the captain's chair. That's why the patient dozed back off. If they had been communicating with the patient, would we have needed that other 0.5 milligram? That's all Monday morning stuff that we can go back and forth on. I believe they did a phenomenal job trying to titrate to effect. In the ER, from the physician's diagnosis, they had a primary diagnosis and a secondary diagnosis of lactic acidosis and rhabdomyolysis. The doctor reported in their EMS report, or in their report, quote, EMS gave 10 milligrams of Narcan, and then, quote, apparently the patient had withdrawal symptoms. So based on the new EMS protocol, the patient was given Suboxone 16 milligrams and transported to the emergency room. And I use those quotes not to badmouth the physician, but this is something that in the MIH space, one of the other things we do is this nursing home stuff. Part of the reason we do that is because there's this breakdown of communication from provider to provider to provider, right? This game of telephone that we all play. EMS didn't give 10 milligrams of Narcan. They got close to 10, but it reads like they just slammed 10 home and called it good enough, right? They did multiple doses in a very intentional manner to try and help this patient. And then we're not giving Suboxone, we're giving buprenorphine, right? Suboxone is Narcan and buprenorphine put together. So it goes to what we talk about when we're talking these peer-to-peer conversations. There's something lost in translation. From the chart review at the hospital side, we noticed multiple doses of Narcan in the ER. before a Narcan drip was initiated, and then the patient was admitted to the floor for this persistent overdose. I was at the time working night shift. I had arrived home about 9 o'clock in the morning and had just laid down to bed when I get a phone call from a doctor, which was one of the first times a physician had ever called me. It was Dr. Michella, and he said that we had a pulse power, which is the fancy way of saying a Prisma Health associated no, right? Like we got the HR, hey, hand slap. So I got up out of bed at 10 o'clock in the morning and came to work. And from that, we had a 24-hour window to respond to the pulse power. And the pulse power came from the physician who presumed that we had overdosed the patient on buprenorphine or given too much buprenorphine or whatever it was, right? I couldn't read the initial complaint, just that it was the patient had to be admitted and we're concerned that the buprenorphine caused it, right? So we did a research team got together on Teams, and we reviewed EMS notes for any discrepancies, found that they were titrating to effect, administered buprenorphine appropriately, and then we found the less than supportive, less than accurate verbiage from the doctor's notes. We did a text-based response to say, hey, we feel that the patient was appropriately treated by EMS. The patient was appropriately treated in the ER. This was just something outside of the purview of the medication, right? In EMS, we recognize that there are times that are patients that are just sicker than we can treat. This patient was just more overdosed, for a lack of a better term, than the buprenorphine was going to fix, right? And so from there, making sure that we meet peer to peer. It's not Parker, the community paramedic who went to a tech school, going to talk to the provider. Dr. Michella went and spoke with the physician, had a peer to peer conversation. And from that, again, hey, this is the medication, here's the research behind it, here's what we understand. That physician as well has become a champion for buprenorphine, has prescribed it in the ER since then. And so there's this continuing of making sure that we're not just saying, oh, they did something like this, we're just going to count them off. Having that conversation, not doing death by PowerPoint, to make sure that we're all on the same page and understand what's going on.
It just gives so much more credence to this whole our practices are based on our lived experiences more than most of our training and knowledge and everything like that. So just having these physicians have these interactions with their paramedics, and I think it probably as we think about, like, these are the experiences that have happened in your program, as those that are listening are thinking, how can I do this at my program, or what are some of the things I can fix? It's having right, we know these things are going to happen, there's no way to fix it 100% in the interim, but having the quick response of the team to say, we know there's some things that are going to happen, we can't prepare for everything, we will take them as they come, but we've got to position champions that can go have those conversations and in a cordial and collegiate atmosphere. So I just think it's so it's like you've prepared for everything, which I love, and this is a great example of that. Again, they're giving it, and they're excuse me, building on the process. So I think that's great. I don't have any other questions on that one, but I'm watching the chat in case any of our audience members do. Other than that, let's dive into case 3. I think this one it tops my list of just interesting ones that you guys put together. You picked some really interesting case studies. And again, just to be the first paramedic to ever give this in South Carolina history, like, should get you a plaque or something, like a gold medal or something. Yeah.
Got a firm handshake from yours truly, I think was.
It sounds better than any plaque you could get.
Yeah. So case 3 was an older gentleman in his 60s who presumably overdosed. Family called 911. EMS was first on scene. There was no first responders. They quote in the narrative, they noted that the patient was found on the bedroom floor with, quote, lines of white powder on the bedside table, and the patient had vomited in the area. Slow respiratory rate, placed on a non-rebreather, noted to be tachycardic, mildly soft blood pressure. The respiratory rate improved as they were assessing and moving and manipulating the patient. They obtained a 12 lead. I think there was maybe some tunnel vision that was going on with a 60-year-old male with a heart rate near 160. Like, maybe we're looking more at AFib, RVR, SVT. And then because of what they were seeing on the 12 lead, they moved the ambulance thinking more cardiac in nature. So once they got on the truck, they initiated a fluid challenge, gave a milligram of Narcan, which reportedly woke the patient up more. And then the EMS primary diagnosis was AFib RVR. The patient did report to EMS that he had snorted an opiate. They found a cow score of 4 due to his heart rate. Notably, in the documentation, we were lacking a little bit when it came to skin condition, notes in the cow score that we would have found one way or the other. In the ER, the primary diagnosis for the physician was an accidental fentanyl overdose. Per the doctor's documentation, the patient is agitated. And then the EMS report to nursing staff said, quote, patient was awake and somewhat upset en route, which was kind of missing from our cow score. And so just kind of from the research coordinator's perspective, looking at a heart rate, vomiting, we could or could not count because it happened prior, but anxiousness, agitation, right, that gives us a cow score over 6. So through our 100% QA of this pilot, we were able to find that this had happened, right? If we just said, oh, he had a cow score of 4 and didn't get buprenorphine next, right? Being able to go back to the hospital documentation to either confirm or deny what was written in the EMS chart gave us a better awareness for each of these reports. Again, anecdotally, we know that we had not had 100% compliance or buy-in from the field. So I always, every time I read these charts, unless somebody came up to me and was like, heck yeah, I can't wait to give it, I had that in the back of my mind, like, are we making sure that we're being thorough in our documentation? And so the lack of documentation led to a conversation from the not clinical research, the education department with this paramedic to say, hey, we were missing some stuff. We just wanted to check base and see what's going on. The patient did have a multi-day stay at the hospital and kept the primary diagnosis of overdose. So even if we remove the buprenorphine and remove everything else for this pilot, we missed, right? We as an EMS organization went down the rabbit hole of AFib RVR because he's 60-something years old. And even with that conversation with the patient in the ambulance where he admitted to opiate use, we kind of missed the mark when it comes to our diagnosis. So even outside of the microscope of a buprenorphine pilot, we should have a clinical conversation with this provider anyway to say, hey, look, here's what happened. And this is where, again, that multiple disciplinary group on this protocol, it needs to be me or Wes Wampler or somebody within the ambulance service organization going to talk with the provider, right? Having Dr. Michella come out of the ER and have the conversation with the paramedic, I don't care, man. You're in the ER, you got 6 nurses, 3 RTs, pharmacy, all this stuff. You're not in the back of an ambulance. You don't know what I'm dealing with, right? So making sure that the conversation is happening as close to peer-to-peer as possible. I'm not on the ambulance. I get it. Your job's much harder than mine as a community paramedic, but I'm just off the ambulance and I was working overtime on the ambulance last week, right? I can have that conversation with a provider much easier than a physician or a dedicated research coordinator can have moving forward. So from that, had that conversation, and then from there, no further issues were identified, right? I can't say that they were a champion for it because they just didn't have the chance to give it after that. But from there, we didn't identify any further issues. So
I think that's a great case to highlight the complexity that is the healthcare system, right? Not every patient has written across their forehead what's wrong with them. And I think they don't all read the textbook before they call 911. So really goes to the importance of the training. And I noted in your discussion that your training included about 50% of the slides being specifically about addiction science, rather than again, trying to hit on the clinical components of this. And I think we try and do so much more in the mental health space as well. What if mental health looked like physical illnesses? Our treatments would be much, much different in the pre-hospital setting. So I think having those collegiate conversations is a great takeaway. We're running up against our timeline, and that's the sad part that I always have to wrap up the discussion. But I want to invite Dr. Gormley and Wes to just share any additional key takeaways that you had from this project before we thank our attendees and move on.
I'll be super quick. The only thing that's super important that I think we touched on a little bit was was what you just said, was that the important part of this and making a program like this successful is the education part of the why to do it. We could teach, but the ACLS goes through how to give epi and amio and when to give in what order. That's important with Bupe, but more importantly is why to do it and how ultimately it would benefit these providers. And there's such a stigma on this, and there's so a misunderstanding of what addiction medicine is and what addiction is, that it's just super important to go into the why of this type of program. And Parker and Dr. Michelle did such a phenomenal job kind of ramming that home. And you had people after the training that kind of had a different perspective on the treatment than they did at the beginning. So I just wanted to reemphasize that point.
I think that's great. Dr. Gormley, anything additional?
I guess I'll just close with one of the big things that Parker and Wes brought up, in addition to the education. The one thing that always bugged us about that third case was like, we just don't know how EMS clinicians feel about initiating this protocol in rural South Carolina. And so Wes did a paper looking at that. We did a focus group with about 99 people, and half of them were rural, just from a rural agency that was from a buprenorphine naive rural agency. And we had some really big themes coming out of that qualitative analysis of stigma, and people that were saying that, if they don't have withdrawals, they're not going to learn. Why would we give buprenorphine? And learning and getting those perspectives from people is something that I wish we had done with our agency personally, so that we could incorporate that and know exactly how to tailor education. And so I think that piece is extremely important. And if you're interested in learning more about the perspectives that we found, you should consider Wes's paper, which is also published in this same issue.
I was going to hit that there's several other good papers from this author team in that in the supplement. So I encourage all of our readers to please check that out. And again, a huge thank you to the author team for joining us and for this great work. I echo the comments of Jeff and Tony that this really is continuing to advance the practice and the treatment of patients suffering from opioid addiction and overuse. So again, thank you, our author team, for joining us and for sharing their insights and their knowledge. We couldn't be more appreciative of that. With that, I want to remind all of the attendees, we do have our educational podcast coming up Friday, October 24th at 10 a.m. This looks into pediatric simulation and is it sim ready? It's a really interesting set of research that they found. And then join us again, same place and time next November 10th, Monday, 10 a.m. Again, same place, same time for our next clinical journal club. Again, thank you to our sponsors, ESO and Limmer, for providing us the support for this podcast.
We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website, prehospitalcare.org. A special thank you to our sponsors, Limmer Education, providing educational tools for success at every stage of your EMS journey, and ESO, dedicated to improving community health and safety through the power of data.